Hello everyone, welcome to this next module on respiratory system. The topic is a very simple and straightforward but a clinically relevant topic, pneumothorax. First of all, let's try to understand what pneumothorax is. Simple, right? You know that as the term suggests, pneumo. Okay, you have excess air in the pleural cavity. Okay, you have excess air in pleural cavity in pneumothorax. So when I say pleural cavity, it is the space between your parietal pleura and the visceral pleura. And always remember that in normal individuals, what about your intrapleural pressure? Is it positive or negative? It is a negative one. Okay. So intrapleural pressure in normal individuals is negative. Now this is very important because it is this negative intrapleural pressure that will allow the expansion of the lungs. Okay, that will normally allow the expansion of the lungs. But when it comes to pneumothorax, when there is air in the pleural cavity, what this can do is that it can prevent the expansion of the lungs and subsequently can lead on to lung collapse. Okay, it can lead on to lung collapse. Okay, so that is what happens in your pneumothorax. So after having understood what is pneumothorax, let's try to see why. Why does air occur in the pleural cavity? What are the causes? So let's see the why of it. The pneumothorax can be classified, okay, based on the etiology. You can have a classification of pneumothorax, and the classification is into two. One is a non-traumatic pneumothorax as well as a traumatic pneumothorax. The non-traumatic pneumothorax is also referred to as a spontaneous pneumothorax. Spontaneous pneumothorax. Traumatic pneumothorax can arise in two settings. One, it can be a iatrogenic one, iatrogenic, or it can be non-iatrogenic. Okay, non-iatrogenic. Now, iatrogenic means it is you are actually inducing pneumothorax in a patient because of some procedural complications. So often this occurs in the setting of an insertion of say a central venous catheter. You are attempting to put a central venous catheter and you are injuring the pleura and there is pneumothorax. So it can also occur while you are attempting a bronchial biopsy. Okay, you are attempting a bronchial biopsy also. There can be an injury to the pleura and subsequent pneumothorax. The non-iatrogenic pneumothorax, okay, can be as a part of say trauma due to some road traffic accident. So this again can be because of either a penetrating injury, okay, a penetrating injury, or it can be because of a blunt trauma as well. So either because of a penetrating injury or because of a blunt trauma you may get this. Alright, okay. Now coming to non-traumatic or spontaneous pneumothorax. Non-traumatic or spontaneous pneumothorax, you can classify it into two. One is a primary spontaneous pneumothorax and other is a secondary spontaneous pneumothorax. Primary and secondary. Now what is this primary spontaneous pneumothorax and what is the secondary spontaneous pneumothorax? Primary spontaneous pneumothorax means a pneumothorax that develops in an otherwise normal lung. Okay, so the patient is not having any already underlying lung disease, no underlying lung disease is there, and still he is developing a pneumothorax. That is what you call as the primary spontaneous pneumothorax. Okay, where you have a no underlying lung disease. There is no underlying lung disease. Whereas in case of secondary spontaneous pneumothorax, the patient has underlying lung disease. Okay. Primary spontaneous pneumothorax is likely to occur in individuals who are tall, thin and smokers. Okay, who are tall, thin and smokers. That is what you call a primary, that is the scenario in which you usually develop primary spontaneous pneumothorax. And secondary spontaneous pneumothorax can be due to varied etiologies. Again, the most common one is in the context of a COPD, that is your emphysematous phenotype, where a patient can develop rupture of the bulla and you can have a pneumothorax. Okay. But remember, the secondary pneumothorax has lots of other etiologies also. So for your exam, you have got to know in detail regarding the etiologies of your secondary pneumothorax. Okay. So just coming to the list of the causes of your spontaneous pneumothorax. So you can have, I told you, a primary pneumothorax, okay, and where an individual is very tall and thin. He may have some subpleural blebs. There is no previous underlying lung disease, but maybe at the time of pneumothorax, suppose if the patient has expired, you are doing an autopsy, you are finding that there are some subpleural blebs. So there is also a viewpoint that though you say that primary spontaneous pneumothorax occurs in individuals without lung disease, there is always a possibility that they have some underlying subclinical lung disease which was not manifesting. Okay, so there is a viewpoint like that, you have got to know. But definition wise, there is no underlying lung disease in patients with primary spontaneous pneumothorax. And cigarette smoking, I have already told you. Individuals with cocaine and marijuana exposure are also at increased risk of developing a primary spontaneous pneumothorax. So are maneuvers like Valsalva and diving, which will increase the transpulmonary pressure. Okay, see, these are the settings in which you develop a primary spontaneous pneumothorax. Secondary pneumothorax, I already told you, common one is the emphysema. But let me remind you again that do not always think that all causes are because of emphysema. There is a big list of conditions which can cause a secondary pneumothorax. You can have airway diseases like cystic fibrosis, asthma and COPD. As a part of infections like pneumocystis jirovecii, tuberculosis and necrotizing pneumonia, you have got to know that two organisms, especially your Staph aureus and Klebsiella, they are very well known to produce pneumatoceles. Okay, they can produce pneumatoceles, and the rupture of which can cause pneumothorax. Okay, and certain congenital lung diseases also can predispose to pneumothorax, like congenital pulmonary adenomatous malformation and a congenital lobar emphysema. Okay, interstitial lung diseases, though less likely, can also produce pneumothorax, sarcoidosis, Langerhans cell granulomatosis. Connective tissue diseases, very, very important, Marfan syndrome. Now this can be asked as a question because Marfan's syndrome, they are very likely to have pneumothorax as a complication, and not just Marfan syndrome, other connective tissue disorders like Ehlers-Danlos, juvenile idiopathic arthritis, polymyositis, Bird-Hogg-Dubé syndrome are some of the other syndromes that you should know. Most important is Marfan and Ehlers-Danlos. You may get a clinical scenario of a patient with a Marfan syndrome developing a acute onset breathlessness, and chest x-ray may be given. So again, it is a simple straightforward question. Malignancies can also predispose, lung malignancies, either a primary malignancy or a metastasis. Airway obstruction like a foreign body aspiration, and thoracic endometriosis especially can cause pneumothorax, that is called your catamenial pneumothorax. That is, some females associated with their menstrual cycle may develop pneumothorax. So that again is related indirectly to the hormonal imbalances, and such a pneumothorax is what you call a catamenial pneumothorax. Catamenial pneumothorax. This again is very, very important. Okay. All right. So these are the causes of the pneumothorax. Very, very important one that you should know of. Okay, you might be asked clinical scenarios based on this. Now, in addition to this classification of pneumothorax based on the etiology, another way of classifying pneumothorax is based on the classification into your closed pneumothorax, open pneumothorax and tension pneumothorax. Okay, it is very important to know these individual entities as well. What is a closed pneumothorax, what is an open pneumothorax, and the most important one, tension pneumothorax. So if I was asking some question for the exam, my question would usually be on tension pneumothorax because it is such an important entity that you should know. Okay, so listen to it very carefully. So let's try to see what are these terms. Okay, closed, open and tension pneumothorax. See, closed pneumothorax means a pneumothorax has happened and you have some air within the pleural cavity. But then what happens is that this air which has been there in the pleural cavity is sealed off from the external environment. By which I mean, you see here the first picture, the closed type of pneumothorax. In the right lung, there is air inside the pleural cavity. But see, it is not communicating with the airways of the lungs. Okay, so there is no exposure to the atmospheric air there. So that is what you call the closed type, where the mean pleural pressure is again more or less negative. Okay, why negative? Because it is not communicating with the external air. So externally you have the atmospheric pressure as 760. So if there is a communication, it would actually become a pleural cavity pressure would be a positive one, and that would again compress the lung parenchyma more. So the closed pneumothorax, again there is no such communication that is happening. The open pneumothorax is where the pleural cavity where air has been trapped is having a communication with atmospheric air, but that communication is a two-way communication, because as you can see here, from the airways you can see the connection to the pleural cavity, and also the air from the pleural cavity is going through the airways also. So there is a two-directional pass. So that is when the mean pleural pressure would again be similar to your atmospheric pressure. Okay, so why? Because there is flow of air into as well as outside the pleural space. That is called a open type of pneumothorax. Now the last one, the very, very important one, is called a tension type of pneumothorax. So this is a dangerous entity. Okay, just keep that in mind. A very dangerous entity where there is a communication, but the problem is there is a communication in such a way that the atmospheric air is actually coming into the pleural cavity, but there is no means of escapism of the air inside the pleural cavity to outside, by which the air would keep on accumulating inside the pleural cavity. Okay, it's almost like a ball valve mechanism. You are having air coming into the pleural cavity, but it is not going outside, and because of which the mean pressure can be positive. There is so much of positive pressure inside here, and because so much of positive pressure is there, there can be to a greater degree you can have a lung collapse. Are you not having lung collapse in other entities? The closed and the open one? Yes, you are, but there is a significant degree of a lung collapse, and the mediastinal shift also occurs. Okay, as you can see here, because you have too much of positive pressure inside your pleural cavity, there also occurs a mediastinal shift in this. Even you can have a significant tracheal shift. Tracheal shift can also occur in the open type of pneumothorax, but again, it is a tension type of pneumothorax that is likely to produce more consequences. Okay. So tell me, are you very clear with these three entities? Yes or no? The closed, the open and the tension type of pneumothorax. Okay. So I hope you are convinced that maximum consequences would occur with our dangerous tension type of pneumothorax. Yes? Alright. Now, having understood the classification of pneumothorax, let's now see the clinical features. So pneumothorax is one cause of an acute onset breathlessness. It is one cause of an acute onset breathlessness. Very, very important. Okay. So patient presents to the emergency department with an acute onset breathlessness. That is a usual scenario. You may have pneumothorax which are smaller, okay, which might not produce a significant degree of dyspnea. So in this breathlessness also, the degree of dyspnea would depend upon the severity of the pneumothorax as well. So patient having an acute onset of breathlessness presenting to the emergency department. Now suppose if it is a tension pneumothorax, okay, the other type of pneumothorax would present with breathlessness, but the problem with tension pneumothorax is so much of positive pressure, because of which so much of intrathoracic pressure is there. So that will decrease the venous return to the heart. That will decrease the venous return to the heart. Subsequently, when the venous return is reduced, when the end diastolic volume is reduced, there is a decrease in the cardiac output as well, which means the patient can have a shock or a hemodynamic compromise. Okay, you can say the patient is having a hemodynamic compromise. So if there is a significant tension pneumothorax, patient also may be developing cyanosis. Okay. So remember, it is a very, very dangerous entity is this tension pneumothorax. So that is how the patient presents to you in the emergency. Okay. Alright. So if it is a patient who has an underlying lung disease, sometimes there is a chance that you might mistake the diagnosis. For example, it might be a patient who is already diagnosed with a chronic obstructive pulmonary disease, emphysematous phenotype. So when the patient develops a pneumothorax and presents with breathlessness, sometimes you might tend to think that okay, this is just another exacerbation of COPD. So you have got to examine the patient properly, only then you will be able to diagnose. See, this is not a routine exacerbation of a COPD, it is a pneumothorax that has developed. So let's see what are the examination findings. So on examination, definitely the patient will be having tachypnea and even tachycardia also, tachypnea and tachycardia. And if it is a tension pneumothorax, you might be able to see the cyanosis as well, okay, because the tension pneumothorax is the one which is more severe. And when you look at the patient is having too much of a tachypnea, okay, and then tell me what will happen to what are the examination findings in the respiratory system. Something that is very clear is that when you have your air in the pleural cavity, the chest expansion naturally would be reduced. There is a decreased chest expansion, correct? Okay, there is a decreased chest expansion in the side of pneumothorax. And you will find that there is a decreased vocal fremitus and decreased vocal resonance. On percussion, you will find a hyper resonant note. And also you will find that the patient is having probably absent breath sounds. Now another examination finding that you may encounter is that especially in the context of a pneumomediastinum, okay, if there is a pneumomediastinum, that is you have your air that is surrounding your heart as well, the auscultation over the heart might yield something that is known as Hammond's mediastinal crunch. Okay, Hammond's mediastinal crunch, which is again a crunching sound that you hear on auscultation. So these are the examination findings. And always remember, tension pneumothorax, you may also have what? A decreased systolic BP also. Okay, that is only if there is a hemodynamic compromise. All cases of pneumothorax may not have it. So these are the examination findings that you will get in a pneumothorax. Okay. Now just seeing the X-rays. Okay. So remember, X-rays can clinch the diagnosis often. And can you just spot what is the abnormality here? You see here the right side. What happens is that when the air accumulates in the pleural cavity, it will become more dark. The region where you have the air accumulation will become more dark. And are you able to appreciate the lung margins here? Yes or no? So this is the lung margin, and distal to that, what you are seeing is that this particular region, it is air that actually occupies, okay, the pleural cavity. Okay, it is air that is occupying the pleural cavity. Now I'll just wipe it off. I hope you are able to appreciate the collapsed lung borders even now. Yes or no? Are you able to appreciate the collapsed lung borders? Yes? Alright. So this is a pneumothorax, and you can see that the lung borders are very much collapsed also. In your exam, they might give a clinical scenario and just put out the X-ray for you. It is very simple to pick up. Okay? Alright. So you can also observe that in the region of the lungs, are you able to see the bronchovascular markings as well? Okay, this particular region, you will be able to see the bronchovascular markings. Are you able to appreciate now? Compared to the other one where it is appearing more dark. Okay, so that is again something that would help you diagnose a pneumothorax. Now another named sign in pneumothorax, can you find out where is the pneumothorax this side? Is it left side or right side? This again is a right-sided pneumothorax, and I showed you this picture here to show you a particular sign. First of all, I hope you appreciated the collapsed lung borders here, and you are able to appreciate that here you have the vascular markings, bronchovascular markings are not there. But are you able to appreciate that your costophrenic ankle is appearing very deep in the side of your pneumothorax compared to the other side? Yes or no? So in the right side, the costophrenic angle appears again very deep, and this is referred to as a deep sulcus sign. Okay, deep sulcus sign. Now mind you, this sign, your deep sulcus sign, is commonly encountered when you have a pneumothorax developing in a patient in ICU who is probably supine. So that is when the air actually goes more down, and you are able to see the deep sulcus sign when you take the X-ray also in the supine position. Okay, that is when your deep sulcus sign is appreciated, because in the erect position there is a higher chance of air ascending up. So it is in the supine X-rays that you are likely to see this deep sulcus sign. Very clear. So we have understood how pneumothorax is classified, how it clinically presents. Okay, so X-ray is going to help us. So what about the role of CT thorax? CT thorax will help you to find out if there is some underlying lung disorder, because we have seen a whole list of secondary causes. Okay, the secondary spontaneous pneumothorax we have already seen. So that will actually help us. But in the emergency setting, it is going to be the X-ray that will help you diagnose this condition. Now what about the treatment of pneumothorax? Treatment of pneumothorax, the guideline which I am going to share with you is the guideline of British Thoracic Society, or your BTS guidelines. So British Thoracic Society guidelines. So that is what we are going to discuss. So let's see the British Thoracic Society guidelines, okay, about the management of pneumothorax. But first of all, let me tell you one thing. Each and every case of pneumothorax is not managed the same way. Just like as I told you, the manifestations of pneumothorax would depend on the amount of air that has got trapped in the pleural cavity and the significance of the lung collapse. How much the lung collapse has happened? Is there any hemodynamic compromise? It depends on all these factors. So the guidelines also again is based on that. So, but remember, if the patient presents with a clinical scenario of tension pneumothorax, where you find that the patient is reaching your emergency, he is in significant respiratory distress, and it is an acute onset breathlessness, probably is having a COPD also underlying, and you have examined, you find that all findings are consistent with a pneumothorax. You've taken X-ray also maybe if there is time, otherwise do not even waste time for your X-ray. So in such a scenario, what you can do is that, see, it is a tension pneumothorax. If you delay so much, suppose your X-ray facility in your emergency is slightly at a distant point. So in that scenario, if the patient is presenting to you with hypotension, if you are confident in your clinical skills, I don't think, for a tension pneumothorax, okay, where the patient is in significant hemodynamic compromise, then you should not wait for a X-ray. And in such a scenario, what you should do is that you are trying to save the life of the patient. So what you should do is that you are using a large bore needle. So you use a large bore needle and you insert this needle into the second intercostal space. Okay, you insert to the second intercostal space in the mid-clavicular line. And when you insert such a needle, you are likely to hear the air gushing out. So you might get a hissing sound, okay, in a tension pneumothorax. I again repeat, this is not the management for every patient for pneumothorax. I am talking of tension pneumothorax now. After that, we will go to the BTS guidelines. So you will see a hissing sound, and so that you can relieve the patient of the respiratory distress, and subsequently you can think of the definitive management later. But here the first and foremost priority is saving the life of the patient by means of a large bore needle inserted to the second intercostal space in the mid-clavicular line. Okay, alright. So you will see the patient's relief also, because it was so much of tension, positive pressure inside the pleural cavity compressing on the lungs. So once it is relieved, he shows good improvement. Now I'll take your attention to the guidelines. I have just taken exactly the same picture or the flow chart from the British Thoracic Society guidelines. So first of all, see, if the patient is hemodynamically very unstable, okay. So in such a scenario, what you should do is that you can proceed to a chest drain, that is your intercostal drainage. That is when the patient, has come with probably a tension pneumothorax and is very much hemodynamically unstable. So you have relieved the tension by inserting a large bore needle. But again, you won't sit relaxed after that, because you never know what is going to happen if there is going to be another rupture of another bulla. So if there is some sort of a hemodynamic compromise after, like your initial treatment means if it is a tension, you can put a large bore needle, you can insert a chest tube. And what is the site in which you insert your chest tube? It is going to be your fifth intercostal space in the mid-axillary line. That is where you usually insert your tube, okay, and you will insert your tube there, and you will connect this tube to a container with an underwater seal, okay, okay. So where you will see that when you connect to that underwater seal, you will see the air bubbles also, okay, because of the air. So as long as you have air in the pleural cavity with the patient's breathing pattern, when it is connected to an underwater seal, I'll try to show you a picture of that. Okay, you see here, this is the patient who is having a pneumothorax and it is connected to an underwater seal. You can see the air bubbles, okay, and this part of the underwater seal will be open to air, so you can see the air bubbles there. So once again the patient has settled, what happens is that the air bubbles will not be coming. So you will have air bubbles here. So when the patient is inhaling, you can see this water seal is there, and that will prevent the entry of the room air. Okay, that is because of the water seal. That will prevent the entry of room air to the, because if you have room air entering, then again the problem will worsen, correct, no? So that is prevented by this water seal. Okay, so emergency tension pneumothorax, emergency management you do, and if the patient is having hemodynamic compromise, you go for a chest tube insertion as well. Okay, all right. So the next point is that suppose if the patient, okay, is not in any significant hemodynamic compromise, then what happens is that suppose your patient is above 50 years and is having some underlying lung disease, okay, already, for example, he is having a COPD. In that case, he is likely to have what? A secondary pneumothorax. If he is a younger patient who presents with pneumothorax, this is likely to be a primary pneumothorax. So as per the BTS guidelines, there is a slight difference in the management between a primary pneumothorax and a secondary pneumothorax. But again, remember, the decision making is mainly based on the size, which we are coming to. Now, if it is a primary pneumothorax, okay, you first look at whether the size of the pneumothorax is more than 2 centimeter or not. Okay. Now, what is this size more than 2 centimeter? What does that mean? So, I shall tell you. See, when you take a pneumothorax, okay, when you want to measure the size of a pneumothorax, remember currently we are discussing the BTS guidelines. So, BTS guidelines, what they do is that to measure the size of pneumothorax, at the level of the hilum, okay, they actually measure, okay, in the lateral side, they are measuring what you are seeing as B, okay, the gap between the parietal and visceral pleura at the level of the hilum. I am not saying at the hilum, at the level of hilum that you can see, the gap between the parietal and visceral pleura is taken as B. So that is taken, that is the distance as per the British guidelines. You also have an American guidelines where the apex to cupola distance, that is your A, is taken as the size. So, but currently for practical purpose, we are more relying on the BTS guidelines. So, B is the thickness of the pneumothorax or the size of pneumothorax that has developed. So, this has to be taken. So, just for your information, there is another method where you can estimate the size of pneumothorax based on 3 measurements: A, the second one that is B, and a lower one that is C, and you are adding and dividing by 3. So, you are trying to take the mean, A plus B plus C divided by 3. Okay. So, you are trying to take the mean size of a pneumothorax. Okay. Alright. So, that is clear. So, if the size is large, okay, if it is more than 2 centimeter, then what you should do is that you should go for a aspirate. Now, what do I mean by aspirate? You are using a 16 to 18 gauge cannula and you are inserting, you are putting a cannula and you are also putting a syringe, okay, a 50 ml syringe, and you are trying to aspirate the air. Okay, that is what you call the aspiration. And after aspiration, you see, you can take a repeat X-ray, and if you find that the patient's pneumothorax has decreased in size, then what you can do is that you can evaluate the patient and you can subsequently, go with a conservative management. Okay, because it seems that the aspiration has worked. Only thing is that you have got to evaluate, is this actually a primary pneumothorax? Do I have certain other underlying cause for pneumothorax? That is to be kept in mind. But remember, if at presentation itself, if the size was less than 2 centimeter, you can go for a conservative management. Okay, but remember, it is very important that you monitor the oxygen levels, you see whether the patient is developing any other hemodynamic problems. Okay, all right. So, I hope you understood that. Okay, now if suppose even after your aspiration, okay, it was a probable primary spontaneous pneumothorax, the size was around 4 centimeter. So, you tried aspirating, you took the repeat X-ray, but the repeat X-ray after that also you have a pneumothorax persisting or probably it is increasing in size. In such a scenario, you will have to go for your ICD. That is, you have got to put your intercostal tube and you have to connect it to an underwater seal. Okay, that has to be done. What about a secondary pneumothorax? There again, the decision making is dependent on the size. If the size is more than 2, the guideline says, you can directly go for the chest drain. Okay, you can put the intercostal tube directly. Okay, that is when the size is more than 2 centimeter. Okay, now this is one again common scenario which I am sure at least some of you would have seen. That is, patients presenting with already a diagnosed case of COPD, presenting to the emergency with an acute onset breathlessness, being diagnosed as a pneumothorax, a large size pneumothorax, you're straight away, maybe in the emergency itself, putting a chest tube, okay, and securing it. But if it is a smaller sized one, okay, if it is 1 to 2 centimeter, in that case you can try aspiration. But most often, as you see here, in secondary pneumothorax, you would prefer to put a intercostal tube. Okay, that is one major difference between a primary pneumothorax and a secondary pneumothorax. Because in secondary pneumothorax, you already know that the patient is having some other underlying lung disease. So again, you would like to secure, the lung by putting a intercostal tube, and so that you are also safe. But if the size is 1 to 2 centimeter, you can attempt aspiration as per the guidelines. And if there is no success, you can go for the chest tube. But very small pneumothorax, okay, suppose if it is a secondary spontaneous pneumothorax, but the size is very, very small, in that scenario, you can go for a conservative management. Conservative management. So you must give the patient oxygen, you must monitor the oxygen levels, okay, always watch out for the hemodynamic parameters also, okay. A good evaluation is always necessary. So keep this in mind, the flow chart for evaluation of a secondary spontaneous pneumothorax, very, very important. The management of pneumothorax, both the primary as well as secondary spontaneous pneumothorax is important. Remember tension pneumothorax, remember about the wide bore needle insertion. Secondary spontaneous, most often you will go for the chest tube. Primary, most often you will go for the aspiration if it is a larger sized one. Okay, if not responding, you will go for the chest tube. So that is how you will manage a case of a pneumothorax. So what is the basic summary of what we have learned so far? In your exam, this is a likely question. The summary is that any patient with an acute onset breathlessness, especially if he is having some underlying structural lung problem, or maybe if he is having a marfanoid habitus, a tall, thin habitus who is a smoker, always consider pneumothorax in the differential. Always watch out for any hemodynamic compromise. If it is a tension pneumothorax, remember it is a medical emergency. Do not waste time, because by the time you send the patient for X-ray, it might be too late if the patient is having significant hemodynamic compromise. So use your clinical judgment, whether you have time available for a X-ray or you should intervene then. So, and then manage accordingly. Okay, so this is a very, very simple and a straightforward topic. Okay.